Think we are live.
I
Uh,
think we
a very, very good evening to all of you who have taken time out on a Saturday evening. Know that, we understand that as doctors, it is very difficult for you to take that time out, but all of you are joining us live. A very, very good evening to all of you. I'm Ravi. I represent DocTutorials over here, and with me are seven wonderful pediatricians, right? Last week, around the same time, we had conducted the first round of the DNA quiz, and we were able to find the top 10 people, seven of whom who have joined top the top pediatric residents across India. Seven of them who have joined us. We have with us Dr. Aditya, Dr. Souvik, Dr. Ravi Prakash, Dr. Kalyan, Dr. Karthik, Dr. Shravani, and Dr. Swati as participants. And the grandmasters of the quiz are going to be Dr. Sandeep Sharma and Dr. Babu Madarkar. And all of us here are very, very happy that you have joined us to uh, enjoy this quiz. This quiz is not only going to be academically engaging, it is also going to be probably helpful for you if you watch it for in terms of how an academician and an experienced clinician approaches a particular case. So it is also going to be useful for you in a case discussion viva kind of a setup when you are going to appear for it. So without much ado, let us begin with the quiz. But just before we begin the quiz, I would like each of you to introduce yourself. And I have with me two people who don't need any introduction. I have Dr. Sandeep and Dr. Babu with me. But before that, Dr. Sandeep, could you ask the other colleagues of yours to introduce yourself?
Sure. Thank you, Ravi. Good evening, everyone who are listening to this. Some of you will be listening to it live on YouTube channel, and some of you will be listening to this in a recorded format. So, irrespective, if you are a pediatric resident, you are definitely going to benefit from this session. Also, as a passive listener, for the simple reason, the questions that we are going to pose to these bright people in pediatrics, these residents at pediatrics, they are going to be useful for all of you. They incorporate some elements of clinical practice. They incorporate Nelson 22nd edition and also some controversial things which you come across, and it is going to be beneficial to all. I'm Dr. Sandeep Sharma. I am pediatric faculty at DocTutorials, and I'm also a part of the residency program at DocTutorials. So we are running this program. I'm joined by my senior colleague, Dr. Babu Madarkar sir. Dr. Babu sir will be joining us shortly, technically, and sir will be introducing himself. Due to some last minute issues, his flight got postponed. He's on the way. Sir has joined virtually, but he will be talking to all of you later on. I've done my MD Pediatrics from PGI Chandigarh, and I'm a clinician come educator. When I'm in Chandigarh, I do practice, and other time I'm teaching students for various competitive exams. And I'm very happy to tell that Dr. Babu was my senior resident. I have learned all the fluid management, intubation, and all those procedures, as many of you might be learning from your senior residents from Babu sir. So it's my privilege to be on the same panel with him, and please continue with the session. And all of you, before we start with the quiz, can you just briefly describe your name, what year of MD or DNB you are doing, and what place you belong to, and what is your place of current ongoing MD or DNB? So over to you. We can start with the ladies first of all. Dr. Shravani, if you could please tell about yourself. You can turn on the mic and please talk.
Good evening, sir. My
Good
name is
evening.
Shani. I am from NRI Medical College, Vizag, Andhra Pradesh, third year.
Okay. Third year. Great. So I hope you are doing good. And next we have Dr. Swati with us. Dr. Swati, if you could introduce yourself.
Sir, I am third year pediatric resident from IMS BHU.
Great. And then we can move over to the men. Dr. Karthik, first of all.
Sir, I'm Dr. Karthik, PG third year from RML Hospital, Delhi.
RML. Great. Delhi, it's raining quite heavily, I just heard.
Yes, sir.
So then Dr. Aditya is there. Dr. Aditya Kamiseti.
Good evening, sir. I'm Dr. Aditya. I'm actually from Visakhapatnam, Andhra Pradesh. I'm currently in sixth semester pediatrics in PG Chandigarh.
In PG Chandigarh.
Yes, sir.
Okay.
I'm a junior.
You're quite a junior. So Chandigarh, it's not raining. So it was
No,
quite
sir,
hot.
actually, it's quite
Quite
sunny
hot.
today. Yeah.
Yes, quite sunny today. Great, great, great. Then we have Dr. Ravi with us. Dr. Ravi Prakash, please introduce yourself.
Good evening, sir.
Good evening.
Basically from Varanasi, and I'm currently in JR2 at Kolhapur, sir.
Kolhapur. Awesome. And then we have who's there? I think Dr. Sovik. Yes, Dr.
Sir,
Sovik.
good evening, sir. I am Dr. Sobik Mondal. I am currently a third year PGT in Bankura Sammelanari Medical College, West Bengal.
Yes, Pankura Sammilini. Yes, I've been there once upon a time, way back when, I was taking demo classes for going over to West Bengal. So it's a small college, but for you might be knowing already a lot of, toppers come out of your place. So it's a
Yes, sir.
quite a good place to do your PG from. So great, wonderful people, wonderful students. I don't think anyone is left. All are covered.
Kalyan, sir.
Dr. Kalyan is there. Dr. Kalyan, sorry. The screen is showing limited faces. So, Dr. Kalyan, please.
Hi, sir. Myself Kalyan from Rangaraya Medical College, Kakinada, Andhra Pradesh State, sir. I'm doing senior residency in RMC.
Okay, awesome, awesome. So we also have a senior resident here. Great. So it's all of us are pediatricians, and this quiz we are going to go. There will be two rounds. Details Ravi might have told you already. For the sake of audience who are listening to this, I just want to tell you a few things. Initially, these students who are sitting here, they have already qualified a prelim test which was held on the DocTutorials app. And so they have been chosen among the multiple people who had taken that test. Out of this, initially there will be a first round where we'll be doing a MCQ based quiz. All the questions have been taken from across the systems of pediatrics, and out of them, there will be 15 questions. Time allowed will be roughly 45 seconds or so, and the time clock will begin. It will be automated for everyone. The earlier you give the correct answer, the more credit you will get. So there is, and obviously, if you have marked wrongly, you don't get any discredit for that. So you have to mark fast and you have to mark correct. So accordingly, the software will be marking you. So you will be checked for both the things, accuracy as well as the speed of answering it accurately. Secondly, we will be seeing that the questions are at the level of PG only, but some questions will be on the simpler side, some questions will be on the clinical, tougher side. Out of 15, 10 questions are based upon Nelson, 3 questions are based upon AIMS protocol, and 2 questions are based upon other resources, including one journal. So this is how we are going to go. And then out of these people, 3 top students will be selected who will go to round 2, in which we will be discussing clinical scenarios, differential diagnosis, and treatment. And there we will be checking a typical bedside kind of a case scenario will be given. And based upon how you are answering, there will be multiple questions related to that single case. Obviously, the same person cannot be given. So in that case, what will happen is one student will be given one system and one case, which will be randomly selected. So there will be no preference order. Yes, there will be a bit of luck coming into play because you can say, sir, I have read everything except this system. But again, luck will always be there. Tomorrow you are doing your MD or DNB final exam and you get a bad case. You cannot say, sir, this was the system I did not prepare for. So that thing will be there, and that thing we are going to replicate here as well. So over to you, Ravi. We can start with the round 1.
Yeah. So all of you are a part of the WhatsApp group for this particular session, and I have shared the QR code of joining the quiz on Kahoot on that WhatsApp group. I'm waiting for you to join over there.
Ravi,
I
please help
yeah,
Souvik in joining. He's posting a query in the group. He
yeah.
needs
I
some
have
assistance.
already I can already see Dr. Ravi and Dr. Karthik have joined.
Sir, I have signed up the app right now. What to do then? There is
You just have to scan this QR code from any scanner. I mean,
okay,
from
okay,
your Google
okay, sir.
scanner,
Okay,
Google
sir.
Lens,
No problem.
from your mobile, and you'll be able to join. Dr. Aditya has joined. Once all of you join, click on start and the quiz will begin, and you will be able to see the questions both on this screen as well as your mobile, and you have to answer the correct answers there. You have to mark the correct answers there. Dr. Kalyan is in, Dr. Souvik is in.
Doctor, can someone rename hello to the actual name? Yeah,
Yeah.
Dr. Swati.
Swati is here. Dr. Shravani, just confirming, are you hello?
I'm not able to join, sir.
All right. Okay. Can you check this QR code? Can you scan this QR code on the screen?
Okay, wait. One.
Yeah. Okay. Dr. Shravani has also joined. All the 7 participants we have today have joined the quiz, and I'm going to begin it. So before the question, complete question with options is displayed, you'll find that one part of the question, only some part of the question will be there in front of you, and then the complete question will be displayed, and you will be also seeing a timer over here. Dr. Swati, you have dropped. Yeah, Dr. Swati is back. So I am beginning the quiz. Dr. Sandeep, you can take them through the questions.
So question number 1 is a child was having obesity, hypogonadism, hypotonia, and polyphagia. He's suspected to have Prader-Willi syndrome. So you know the diagnosis. Which of the following best describes the genetic basis of this condition? 4 options are there. Please click. The students can click what is their likely.
Sir, it is not coming in my.
You should be able to click one of the options, sir.
You have to click one of these options.
Not here, on your where you have joined. Yeah.
Sir, I am not getting the access.
You have joined the quiz, sir. I
Yes, sir.
see that you have joined the
But it
quiz.
is not coming in my.
Hi, Ravi. Yeah, Ravi,
Sir,
can I come in, Ravi?
my screen.
Yes.
Yes, Babu sir, yes.
Yes, sir.
Yeah, Ravi. Yeah. I mean, as I see, Souvik is not able to get this in his screen. I think we'll let us wait till he gets the things done.
Oh, hello, sir. Network issues are there. I couldn't see the first question only.
Yeah. So is it seen in your screen?
I
I
can see
can't.
I can see here that all 7 of them have answered. 4 of them have answered for option B, and 3 of them have answered for option 1.
Question was not visible, just marked anything, just
Anything.
pressed on the screen and
Sir,
it
based on the
went.
screen, it was the color was only mentioned. I thought that
Yeah.
question will be there. Actually, there is only color, so I didn't understand what to do. I clicked one actually.
Yeah, same me too.
Understood.
Ravi,
So
do one thing. Go
yeah,
back and we will not include this question for evaluation. Show this question again and make sure that it is visible to everyone. So then we can start with it.
yeah. Just let me. Sorry. I'll just restart the quiz, sir. I'll just try to restart the quiz, and I'll share a QR code again. So you have to answer on from the device that you are joining the quiz through, and this is the QR code to join.
Everyone, please join again.
Wonderful. All 7 of you seem to have joined. So you have to answer the questions on the screen that you have joined the quiz from that device. And I'm starting the quiz over here.
The first question we will not be taking into account because you have already seen, but try to see if you are able to answer it or not.
I request no one to answer to the first question.
Can you see, all of you can see the options?
Yes, sir.
Yes, sir.
Yes. So this is
Yes,
how
sir.
you are supposed to answer the question. The answer to this question, I think we have already seen. This is Prader-Willi syndrome. Prader-Willi syndrome is a condition where genomic imprinting is involved. We have genomic imprinting as a non-Mendelian mechanism which operates in conditions like Prader-Willi, Angelman, Russell Silver, and some varieties of Wilms tumor as well. So basically, genomic imprinting is a phenomena which you need to understand that it is a normal phenomena. And let me tell you one thing. I was just trying out ChatGPT and Perplexity. Both of them gave me wrong answers to this question. So it was a fun thing, which also shows the limitation of AI. So people who are claiming right now that AI will replace uh, doctors, I think that is going to take some time because AI also depends upon the resources on which it has been trained. And there are many resources which get the equation wrong. You need to understand that imprinting is a normal phenomenon. Normal phenomena means, I'll give you an example. There is a gene called a SNORP gene. It is present in you and me. It is present on chromosome 15. We have two alleles. We have the paternal, my dad gave me, and one mother gave me. Now, in every normal human being on chromosome 15, this SNORP gene is maternally imprinted. Imprinted means silent. So right now, the only functional SNORP gene in me and you and all of us who are normal people, that is our father's SNORP gene allele. You understand? Maternal gene is silent, that is imprinted. Now imagine that mutation happens in the paternal allele, which is functional. So what will happen? Maternal was already silent. Father one is also not working. Now gene product will not form, and that will cause the so-called Prader-Willi syndrome. So what is the answer? Look at the options given. So maternal imprinting is already there as a normal phenomena. On top of that, when the normal functional paternal gene gets deleted, that produces Prader-Willi. Angelman, it is the reverse which happens. It's a different protein. It is a E3A gene present on chromosome 15, where it is paternally imprinted and then maternal deletion happens, leading to the disease. There are other mechanisms involved, but when we talk about genomic imprinting, these two mechanisms you need to remember. And also remember that imprinting is a normal phenomena. It is not abnormal phenomena. It is the deletion of the functional allele which causes disease manifestation. Right? So this is a very, very important concept. This is one topic for those who are targeting super specialty exam, fellowship entrance exam, and even your OSCE exams. 100% some way or the other, it will be asked to some candidate. Now that candidate can be anybody, that candidate can be you as well. So my suggestion to you, after this quiz is over, those who are listening to it, as well as those who are the candidates, please read genomic imprinting from Nelson if you can. It's a wonderful topic to know about. Let us go to question number 2.
So after the first question, because no one has answered to it, this is how the leaderboard will look. After every question, we'll be showing this, right? Let's go to the second question. So we have got 7 out of 7 answers.
What is the correct answer? Bone marrow study. 3 of you have got it wrong, and the answers have been distributed. Let us break down the information given in the question. Child has presented with multiple ecchymosis over the extremities and neck. So it could be a thrombocytopenia. Let us have a look at what the examination findings say. Splenomegaly is there, lymphadenopathy is there, and lab findings show all the 3 lineages getting affected. There is anemia, there is leukopenia, and thrombocytopenia. If you are thinking of getting a BT done, all BT will show is thrombocytopenia. Already, when you know platelet count is low, there is no point in doing bleeding time. Platelet aggregation test will be done when you are suspecting some platelet functional problem or some rare, bleeding disorders. Whenever you have a pancytopenia, your possibilities will include aplastic anemia. More importantly, this looks to be leukemia. Leukemia needs to be ruled out. And for that, bone marrow study has to be done. Bone marrow aspiration or biopsy will be needed. If you are thinking why it is not ITP, remember the funda. There is a line given in Nelson 22nd which says presence of hepatosplenomegaly and significant lymphadenopathy is a point against ITP. So ITP will not be the answer. You have to rule out malignancy in this child, and for that, bone marrow study has to be done. Differential diagnosis will be malignancies. It can include other causes producing pancytopenia. Among the options given, again, coagulation profile has no effect on this because it is not a coagulation disorder that we are talking about. So, Babu sir, you want to add something, sir?
Yeah, all fine. Additionally, there is one evidence wherein all the 3 cell lines are affected. When all the 3 cell lines are affected, then it goes in favor of something wherein we have to see the production is getting affected, or there is bone, leukemias kind of scenario. So we have to do marrow study.
So I think we can see the scores and go to the next question. Where are we standing right now? Why differential score? It also depends upon accuracy of the question. It also depends upon speed of answering, right? So remember both the things at the back of your mind. Let us go to the next question. Okay, the time is over. I think 7 were supposed to answer. One of you have not answered it yet. Who's the person who failed to answer this in the time allotted? So we'll see. See, Noonan syndrome, Legius syndrome, NF1, they all belong to the category of the so-called rasopathies. Dear friends, rasopathies has been a known topic. We all have been reading when we were young students as MD, MS, as MD, DNB students from review articles. New Nelson has expanded on it, and there is a proper new chapter on this. You can expect something out of it in your university exam for sure, and you will get something out of it in your competitive exams as well. So all of them involve abnormalities in RAS MAP kinase pathway. They are not associated with celiac disease. Celiac disease syndromes are not, these are not the 3 associations. Celiac associations with syndromes include Down, Turner, and to a certain extent, Williams syndrome. Hypogonadism and infertility are not common in NF1 and Legius syndrome. Can occur in Noonan. And HOCM, hypertrophic obstructive cardiomyopathy, is the cause of mortality in Noonan syndrome, but it is not the most common cause there as well. So the only logical answer to this question is the first one, that is abnormalities in RAS MAP kinase pathway. This is all systemic pediatrics, so I am speaking more. Once the things move into the world of neonatology, I will let Babu sir take the lead because sir is the leading person in that. So we have The scoreboard moving up. Souvik is doing fine for now. Let us move to the next question. And all the students who are there, I would advise all of you to please keep the camera open if it is feasible. Yes, all of you have answered. The commonest mistake people make is getting it wrong between Rubinstein-Tybee versus Cornelia de Lange syndrome. Whenever you have facial dysmorphism, the most important thing to watch out is the first thumb and the first toe in these children. It is abnormally large, bulbous, and you can see there is a slight radial deviation of that, right? So there is a outward radial deviation, and you can also see that there is a persistence, although it is the plantar surface which is or the palmar surface will show it better, the palmar and plantar, but the pads will be abnormally thickened and persistent in the tips of fingers and toes. But the most important thing, big large thumb, big large toe goes in favor. It's a spotter image. It is asked in most of the OSCEs of DNB exam. It is asked. This is indirectly also repeated in various competitive exams. The answer to this question is Rubinstein-Tybee syndrome, right? So, Babu sir, anything to add, sir?
Yeah, correct. Fine. There are some overlapping features between these, wherein if you see this Kabuki syndrome and Rubinstein-Tybee syndrome, they have this arching of eyebrows. That is one thing which will actually cause confusion. And the differentiate, there is no specific differential feature, but then Rubinstein-Tybee has broad fingertips and a grimace-like smile, which is how we clinically differentiate. And the columella is hanging down in this syndrome, and as compared to Kabuki syndrome, where columella is not hanging down. It's in fact they have smaller nose.
Correct, sir. Very rightly said. In fact, sir, arching of the eyebrow thing is a very prominent feature in many facial dysmorphism syndromes. And we used to remember it like this, like Shah Rukh Khan was there that time also. If you notice Shah Rukh Khan, he has a very prominent, eyebrows going forward. So we would just remember कि Shah Rukh Khan के photo के ऊपर we would write 2-3 important syndromes. So yes, Kabuki syndrome versus Rubinstein-Tybee, the differentiating feature, as Babu sir said, is the thumb. Moving to the next question. Where do we stand? Let us have a look. Okay. Souvik is doing fine. Shravani is catching up. Kalyan is almost there. Aditya has actually moved up. So great. Three participants have answered all the 3 questions correctly. Let's go to the next one. The question is showing you the sign, which is nothing but Gower sign. Gower sign is a sign of proximal muscle weakness, originally described in DMD, Duchenne's muscular dystrophy, can also be seen in Becker's muscular dystrophy. Apart from that, if there is any condition which has proximal muscle weakness of the hip girdle, that can cause a positive Gower sign. So Pompe's disease, although it is not pathognomic, but Pompe's disease can have proximal muscle weakness in almost 30% patients. And if you look at the literature, it is described, the only GSD where prominent Gower sign has been described in literature, that is Pompe. Juvenile dermatomyositis, again, because proximal muscle weakness occurs, so you can have this. Charcot-Marie tooth disease is a neuropathy. It is a distal neuropathy, and because it involves distal weakness, you will not have a Gauver sign positive in these patients. So, Babu sir, anything to add, sir?
Yeah, the question is like which of the following is distal neuropathy or distal myopathy? That is the question. It is trying to understand the clinical implications of this picture.
Yes. So I think score is moving fine. Students are doing good. Kalyan has streak with 4 correct answers in a row. Kalyan is doing fine. Kalyan is only lagging behind because his speed of answering is a bit lagging behind. But nonetheless, let us continue. Babu sir, please take the lead, sir.
Yeah. The answer for this is when in Addison's disease, things are wherein the corticosteroid pathways as well as aldosterone pathway both are affected. So what aldosterone per se does is it does retain sodium and pulls out the sodium and potassium things are affected in the Addison. So potassium is actually on higher side, which is how the Addison's presents with hyponatremia and hyperkalemia, not hypokalemia. So other things are
Self-explanatory, sir. It's a simple thing, sir, actually, na? Because when we put child, sometimes people start thinking, is there any difference? No, basically Addison disease, you have the damage, there is a deficiency of the adrenal gland hormones. So your glucocorticoid is not coming. So the feedback inhibition is lost, leading to more ACTH, which is causing hyperpigmentation. Apart from that, mineralocorticoid are deficient. So aldosterone is not there. Aldosterone normal function is maintain BP, sodium retention, potassium excretion. So if it is not there, what will happen? Sodium will be low, hyponatremia, BP will be low, hypotension. Potassium will be high, hyperkalemia will occur. But what is the option saying? Hypokalemia. You have to pick the wrong answer because it is saying except. And so your answer is hypokalemia in the question. So let's see the scores. Souvik has streak and Souvik is on number 2. Shravani has caught up, but they are very, very close to each other. So it's a good thing which is going on. Let's go further. What is the answer? Only one has answered it correctly. See, that is the problem. Details will be discussed by sir. I just want to emphasize one thing. This is neonatal resuscitation question. Whenever we are reading NRP, we have done a lot of resuscitations, and I'm quite sure you are doing a lot these days. When we read the NRP, we tend to ignore that bechara small table which is on the side telling you the target preductal SpO2. 1 minute, 60 to 65, 2 minute this, 3 minute this. If you look at that table, 5-minute target preductal saturation is 80 to 85%. This child, 5 minutes, SpO2 is 80%. 80 to 85 is the target. If target has been achieved, nothing needs to be done. Remember, oxygen is a drug. You give it only when it is needed. For newborns, you don't give oxygen, bad for the newborn. You give too much of oxygen, bad for the newborn. Child is not miniature adult and newborn is not a miniature child. Babu sir can elaborate more on this sir's domain.
Yeah. You have already answered this part nicely. Normally, in intrauterine life, babies will have saturations in the range of around 40s and 50s, and which is sufficient for them to, do the bodily functions. So after they are born, it takes almost 10 minutes for their saturation to get normalized in between 85 to 95. And those 10 minutes, we have to accept it as a physiological thing. So there's no need to intervene by offering oxygen and pressures to these babies. But in preterm babies, we start with FiO2 of 30%. And based on again, we have these same saturation targets. But in term babies, we directly start with only with the air, not with the oxygen. So 80% saturation at end of 5 minutes is acceptable. So the table that you mentioned is very simple: 60 to 65, 65 to 70, 70 to 75, 75 to 80, 80 to 85, first 5 minutes. And last 5 minutes, I mean, from 5 minutes to 10 minutes, that whole 5-minute duration, it takes a little longer time for saturation to get normalized from 85 to 95. So we just need to know that table to answer this question.
Basically, don't ignore the small table. So we can see the scores next. Okay. Karthik has moved up. So Shravani is still leading. Let's go further. Great. Everyone has answered it correctly. So it will all come down to how fast you have answered. Basically, it's a CKD child. We know CKD can cause short stature. And in CKD, the type of short stature is generally growth hormone resistant. Even if you give growth hormone, the IGF-1 levels are low, they don't change, and the response to therapy is limited. So we don't generally give a trial also these days. It is seen that if you just correct the underlying acidosis, hyponatremia, and the basic underlying management is done well, then the response to therapy can come in these patients. Since they are asking the first step in management, Nelson actually talks about it. This is a question taken directly from Nelson 22nd. It says that renal transplant will eventually be needed, but it is not the first step in the management, right? First step will be correcting the underlying acidosis. Acidosis is partially responsible for inducing growth hormone resistance. Remember this funda, right? If of course it is not needed also how that does that. You can read the entire review articles, and Bagga sir's book can also talks briefly about it. But this is the mechanism. And so if you correct acidosis, and following which, sometimes giving a small trial of growth hormone after that, after acidosis has been corrected, the patient tends to catch up. And obviously, limb lengthening surgery will not be done till the growth plate fusion has happened. So limb lengthening surgery, Elizarro techniques, they're all employed after the limb length fusion has happened. So C definitely cannot be the answer. So it will depend upon how fast you have answered. Who's up and who's down? So Shravani is still leading. So Shravani is fast with her marking. So let us continue. We are almost halfway done, more than halfway done. Okay. 5 of them have answered correctly, 3 are wrong. So let us have a look. What is the answer? Infantile colic. What is infantile colic? Infantile colic, this is very, very common. there is a rule of three described in Nelson 22nd. What does infantile colic rule of three says? It says that it begins in the third week of life, generally happens about 3 hours per day. It resolves up in about 3 months and lasts for minimum 3 weeks once it has started. This particular phenomena is called as rule of three. Babu sir, you deal with in these infantile colics on a regular basis as a clinician.
Yeah.
Sir, what does a resident need to know from a practical perspective, sir?
The practical perspective, if the baby is crying on day 1, day 2, day 3, first week, you don't have to label it as infantile colic. So that is what happens many times. Baby comes with excessive crying, people end up giving antispasmodic medications and then send the baby. Usually first week, second week, it's because of inappropriate feeding, inadequate feeding. Maybe at times they also cry because of the diaper, wet diapers or diaper rash. These are the common things. So we have to keep the possibility of colic, infantile colic after end of 3 weeks. And if it has to be significant enough to cause distress to the baby and to the family. And usually, although it gets initiated at end of 3 weeks, it peaks up by end of almost 2 months, and it continues. It may be there even up to 3 months and 4 months. But then to make sure that we do not unnecessarily give medications, unnecessarily treat these babies, these diagnoses, these diagnostic criteria have been well set. And it has come again in only in last 2 or 3 editions of the Nelsons. Previous editions didn't have. And colic, treatment of colic lies with only symptomatic care of the baby, like rocking, swaddling, mooing, and feeding well. We don't have to give medications to colic unless it is extreme in terms of causing distress to the baby, and baby is not able to sleep, a lot of pain. Those scenarios we do the medications.
Excellent, sir. So everyone who's listening, 2 takeaway points. Number 1, day 1, day 2, first week, second week, baby, don't try to give antispasmodics. The cause is not due to colic, as Babu sir said. Second, open Nelson 22nd edition. Make sure that at least the 2-3 paragraphs given on rule of three in infantile colic chapter, they are taken care of. It, as Babu sir said, our Nelson did not have it. Our Nelson did not have it. It started from, I think, sir, 21st edition and 22nd edition it came.
Yeah.
So it was not there in the older one, sir.
2021st edition it started. Yes. And it's not there even in the DSM classifications of diseases. It has been added recently.
Yes, sir. So it is also a potential viva point. It is a potential theory point. So all the questions that we are discussing with all of you, later on, like obviously after the results are out, this YouTube video will be available to you. It is good always seeing yourself what you did. And just make sure that you remember these points also and mark them for your exams as well. Let's move further. Where do we stand? So Shravani is still leading. Aditya has moved up. Kalyan has moved up. Okay, let's go further. Next question. Milestones.
Options not visible, sir.
Yes, options not coming. Where are the options, Ravi?
Times.
सर टाइम्स अप आके टाइम्स अप आ गया था.
I know. Options are not visible. There is some option is missing. Bablu, Ravi?
You see the Zoom screen, sir? That I've
No, the options are not coming. And there is no clock and nothing we can see. At my end also, I cannot see.
okay. The screen share is not visible.
No, screen share is fine. The software is not showing the options. Screen share is fine, Ravi. It's not screen share. It's the app. It's the software. Everyone, please wait. They are just resetting it a bit. Anyways, option nobody has seen. Can you please upload, re-upload it, Ravi? Bablu?
Yes, sir.
Dr. Ravi Prakash is on duty. Awesome. Doing the duty and taking the quiz. Residency days now, most of you, I'm telling you, you're going to miss. Right now, you might be thinking, yeah, kya, no time to eat, no time to sleep, getting rebuked by consultants in the morning rounds. And sometimes you're like, okay, life will be so better on the other side. Yes, it will be better in a different way, but this time which you are having right now, you will actually be missing. Telling you. I was in Hyderabad 2 days back and I just caught up with Babu sir. So we were talking about our PGI days.
Yeah, they say there's a saying, no, don't grow up. It's a trap. I think this holds good in this scenario also.
True, sir. The more you learn, the more sad you become. I read it somewhere. It is actually true. Ignorance is bliss. We had planned it on a Saturday evening so that, most of you can still join in. Because most Saturdays, even your consultants will not also be interested. And they will be asking the senior resident for what is the status, not you. Okay.
Sir, is the screen visible now?
Yes, the screen is visible. The screen is visible, Ravi, but we cannot include this question also for the mark, for the scoring. Anyways, it will not matter because nobody saw it. So this was a milestone-based question. I will
Nobody
just
answered.
summarize it for everyone. This was the question. So because nobody has answered it, so it will not be taken into account for the final score. So as you can see, nobody has answered. There was a software error. So question is asking which of the following will not be seen in a 4-year-old child, taken directly from the table of Nelson or Illingworth, whatever you are reading right now. So naming 4 colors generally comes at 5 years of age. Counting 4 pennies correctly, copying a square, standing momentarily on 1 foot, they all come by 4 years. Standing momentarily on 1 foot, in fact, comes around 3 years of age. So it's a basic milestone that you need to know. So the scoreboard will not be moving because this question has not been taken into account. Let us go further and look at the next question. Next question. Everyone get ready.
I'm reconnecting.
Is the question visible, sir?
Yeah.
Yes, visible.
Sir, I'm still connecting. I cannot answer. Hello?
Who cannot answer?
No, it's not. I'm trying to answer it, but its input is not going in. I don't know why. Hello, can you hear me? Hello?
Yes.
Yes, doctor.
Only one has answered. Ravi, problem with the software.
Sir, I think it is an issue. It is an internet issue from my side.
Time's up. We answered.
Net disconnected from Dr.
Sir,
Karthik. I think
hello.
only one. Ravi, how to tackle this now?
Sir, I am getting some internet issues because I have joined the session from the car, right? I was out, so I couldn't connect it from a proper Wi-Fi. I have been depending on my hotspot. We have till now gone through 10 questions, and this was the 11th question,
Okay.
right? So
Right.
the scores till the 10th question is what we know already. And this was the 11th question.
Yes.
Let's just check who answered to this question. There is no change in the scores that I can see on my screen. Can you see the screen, sir?
Yes.
There is no change on the screen. So I think
Yes.
it is one from our side only who has answered this question. No one from the participants has answered this question. So it should not
Correct.
impact overall scores.
Okay. Nobody has moved because if someone is moving up and down, it will show arrow and the numbering will change. It will scroll. So that means nobody from the students edge student side has answered it. So let's
Yeah.
continue. We'll take out all these for final
Sir,
score
excuse
calculation.
me.
Yes, Aditya. Yes, Aditya, please tell.
Sir, I still cannot connect to game pin is showing it's wrong. 7771 to the forward. What it's been showing. I'm not able to connect to the whole thing.
Okay, just a second.
I mean, if I scan the code, will I be able to join? I mean, can I resume the session or will I be joining from the start?
No, doctor. Please don't exit.
You can try joining the code.
It's showing that there's a problem with the game pin.
Are the others also getting the same issue, sir?
Dr. Karthik, Dr. Ravi, are you facing the similar issue?
Or do you know that there is a problem? I mean, what will happen is, what I perceive is they must be pressing that button, but they must have presumed it is right. I mean, it is received by the app.
We can do one thing. Instead of going further, we can stop it at this moment and calculate the total score. Already 10 questions we had originally planned, and 5 we had kept. Okay, if time permits, we will allow it to continue. So, Babu sir, your views on this?
Yeah.
Because if students cannot answer it, then it is not fair for everyone.
Correct.
Because whatever they have answered, all 7 have answered, we will include only those for the total calculation.
Okay.
And I think, Ravi, you can plan it accordingly.
So as for now, till the first 10 questions, this is the leaderboard, sir. We have Dr. Shravani leading at 5,221 points, Dr. Aditya at 4,548 points, and Dr. Souvik at 4,219. Dr. Kalyan has missed out by a very small margin. That's only what 11 marks in terms of the number of questions, or in terms of the number of points with Dr. Souvik. Unfortunately, the software is not responding for us to proceed to the next questions. Uh, so it's best that we call it, we select the top 3 students till now, and we continue with the case discussion, sir.
Yes. So who are the people going forward? It is Shramani, Aditya, and Souvik.
Yes, sir.
So others.
Yeah, it
See,
is.
others. Ravi, please tell about the next step, how we are going to go about.
So, sir, the next round is going to be clinical case discussion that you and Dr. Babu will be taking up, sir.
Yes.
Yeah. So I will stop my screen presentation and you can start your presentation and begin the clinical round. You may decide the order in which you would want to approach Dr. Souvik, Dr. Aditya, and Dr. Shravani.
Okay. Okay. So I think we can follow the same sequence in which they have answered, and it will eventually come down to who has read which particular system and all. So we will be continuing with the same pattern. So first scenario, let me share the screen with you. And how much time are we allowing for this, Bablu? Ravi?
Sir, it on the question, I mean,
Okay.
question and the
Basically,
case. So,
basically, basically,
how,
that will be there will be sufficient time. You can think about it, and then you
yeah,
can give the answer. I will be answering. The entire screen will be visible to you. So I'm starting
yeah,
with the final round. I hope my screen is visible to all of you. Is
yes.
the screen
So
visible?
one case for each participant, right, sir?
Yes. One case for each participant will be
So
starting,
the
and
first,
there will be no passing. There will be no passing to someone. Yeah, after
yeah,
the scoring is done, in case someone wants to add something to it, you are most welcome to do it. But you will not be getting the credit for it.
yeah,
Okay, so we'll be starting. Each team gets a single randomized scenario with multiple questions related to it, including possible DD, approaches, and management queries. There may or may not be a perfect answer, just like it is there when the morning rounds are done, right? The aim is to check the diagnostic acumen and whether you have read the topic and the thought process, what thought process you are having in that we are going to check, and to accept the DD with reasoning. Suppose there is a DD which I am saying and I have three DDs in my mind. But you say, ki, nahi, sir, this can be a DD. And if you can prove it, then it is up to me and Babu sir to accept, even if we feel it is not the perfect answer. If you can reason it and if you can, with your reasoning prove it, we will be able to accept that and give you marks for that. There will be approximately half to 1 mark for every question related to that clinical scenario. One student gets one scenario and then the questions come. There is no negative marking in this. You have to read, you have to see, and you have to answer. Based upon the answers you give, we will be giving you the score for that, and that scoring we will be doing individually. So let us start with the first scenario. Who's going to take? Who's the first one in these score? Who was the first one, Ravi?
Dr. Shravani, sir.
Dr. Shravani. So, Dr. Shravani, are you ready? Please turn on your mic and your
Yes, sir.
camera.
Yes, sir.
Okay. Okay. So we are going to start scenario number 1. This is for Dr. Shravani. Have a look at the scenario. Read the question first of all, and then we can start with the. Once you have read, please let us know, and we can start with the discussion and asking you the answers. I will say it out also. 7-month-old child is being examined by you for delayed milestones, motor milestones. Positive examination findings include hypertonia and hepatosplenomegaly. You are told by the consultant that there is a possibility of sphingolipidosis. Sphingolipidosis points towards a lysosomal storage disease. There are multiple types. So they are talking about sphingolipidosis. So you have to tell, first of all, three differential diagnoses, three possibilities, which you will consider. If there is co-species with angiokeratoma, what could be the likely cause? Because it is very specific finding. So either all or none, either you know it correctly or not. Question number 3 also similar. Then there is and two questions are related to therapy in such a patient. So take your time and start. Dr. Shravani, you can begin with the possibilities. If anything, there is no order. You can pick and tell which question you are marking.
First one, sir.
Okay, first one. What are your possibilities?
GM2 gangliosidosis or
Okay,
Gaucher's disease.
Gotcha.
Okay.
And
Niemann Pick.
okay. Any other possibility?
Fabry's disease.
Fabry's disease. Okay. Let us go to the second question.
Tay-Sachs.
Correct answer we will be discussing afterwards. Next.
Second one, Fabry's disease.
Second is Fabry's disease, you are saying. Okay. Third one,
Third one, Tay-Sachs disease.
Tay-Sachs disease. Okay. Fourth one and fifth one, which one you want to answer first?
Mhm. Fifth one, sir. Fifth
Anything
one,
coming
sir,
to your...
Gaucher's disease.
Which one?
Fifth one, Gaucher's.
Fifth one, Gaucher's. Okay. And fourth, you have to simply say true or false. There is no reasoning for it. Reasoning is not needed. That we will talk when we discuss the answer.
False.
Okay.
False.
She's saying false. Okay. And whenever you have to say true or false, you cannot change. So you have to be very clear. Yeah, false. So she is saying false. Okay. So let us go into one by one. What are the possibilities? Babu sir, you want to say something or should I start?
Yeah, please continue.
Okay, sir. Neonatology, sir, I will be handing it over to you. So this is a patient with sphingolipidosis. This is lysosomal storage disorder that we are talking about. And very nicely put up by Shravani, GM2 gangliosidosis. We have your Tay-Sachs disease as well as Sandoff disease, which will come in GM2 gangliosidosis. She talked about Gaucher. She talked about Niemann-Pick. So the three differential diagnosis is done. So Shravani gets 1.5 marks correct for the first question. Good, Shravani. Question number 2, she answered Fabry. If the patient in this question has core species with angiokeratoma, what is the likely cause? In such a patient where the hypertonia and hepatosplenomegaly is mentioned, Fabry could be a possibility, but the more likely possibility will be GM1 gangliosidosis. GM1 gangliosidosis should always be the first possibility in a hypertonic hepatosplenomegaly less than infant who's presenting with angiokeratoma. The Fabry's disease can have angiokeratoma, but the presentation is a bit atypical, including the age and including the overall picture, and it is a relatively less common cause. So we will be getting 0.5 marks to question number 2. Question number 3, very rightly answered, full 1 mark. If there is exaggerated startle response without organomegaly, the answer will be Tay-Sachs disease. Remember the funda. Exaggerated startle response is also called as hyperacusis. So you have GM1 gangliosidosis, we have GM2. GM2 is of two types. You have Tay-Sachs disease and you have Sandoff disease. Tay-Sachs disease is a deficiency of beta hexosaminidase A, whereas Sandoff disease has both type A and B being defective. The difference between two points you need to remember. Tay-Sachs disease will have exaggerated startle response, which is generally not prominent in a patient of Sandoff. Second thing, Tay-Sachs disease does not have organomegaly, whereas Sandoff disease will have organomegaly in these patients. And of course, cherry red spot will also be present in such a patient. Question number 4, she answered false, which is actually false. Imiglucerase is useful in Gaucher's disease, but it reverses organomegaly. The neuropathy, the CNS damage is not reversed. Nelson 22nd edition says treat enzyme replacement therapy can reverse organomegaly and bony changes in Gaucher disease, but it cannot reverse the neurological damage which has happened. So she doesn't get any marks for this. So 4 she doesn't get any mark. And question number 5, miglustat is drug of choice not for Gaucher's disease. Miglustat is drug of choice for type C Niemann-Pick disease. Type C Niemann-Pick disease. There are three types of Niemann-Pick disease. You have type A, type B, and type C. Type A is acute neuronopathic form, which has a poor prognosis. Type B is non-neuronopathic form. And type C is the one which is associated with abnormalities in cholesterol transport. And this is where FDA has approved miglustat as the drug of choice, and it can produce dramatic recovery in the patient. So Shravani gets a total score. Ravi, Bablu, you can write down. Shravani gets 1.5 plus 0.5 plus 1. That is
3, sir.
3 total score out of 5. So the total marks in this question you can get maximum is 5. So 3 out of 5. Shravani, well done. Very good job. Uh, everyone listening to this, glycogen storage disorders, lysosomal storage disorder is one of the very important topic for your theory exam, for your vivas. You may not get a clinical case on this. Viva sometimes goes on this. OSCEs of DNB questions are asked on this. And trust me, when you prepare for fellowship entrance, super specialty entrance, this topic from Nelson is the rank decider, rank clincher. You don't need to go into details. When you are reading sphingolipidosis, 5 or 6 diseases, and using that information, you can rule out the option and still reach the correct answer. So very well done by Shravani. Good job, Shravani. Your job is done. We move over to the second student. Who's the second student, Bablu?
Dr. Aditya, sir.
Okay. Aditya, are you ready?
Yes, sir.
Yes.
So before we go to this next question, I want
Yes, Babu sir. Yes,
Yeah.
sir. Sir, please, sir.
to ask Shravani, although not be added to the marks, out of the 3 differential diagnoses that she said, one of which was Niemann-Pick's disease. So which type of Niemann-Pick's will have hepatosplenomegaly?
Type B.
Yeah. So and additionally, I mean, I used to always get confused between the Tay-Sachs and Sandoff's. So my friend used to had given me this mnemonic. So Tay-Sachs means Tay's Khan, Sandoff's means sandbag. Sandbag means basically organomegaly. So one disease has organomegaly, other disease doesn't have. The one disease has hyperacusis, other disease doesn't have it.
Yes, sir. Even I have heard about it, but it's been quite some time. So a good thing to remember. Sir has given you some hints to remember that. Also, sir, another thing, Nelson says that Niemann-Pick disease type B, splenomegaly is out of proportion to hepatomegaly. Normally, what happens in most of the lysosomal storage diseases, hepatomegaly is more compared to splenomegaly. This is one condition, NPD type 2. This is something which is there in review articles as well, that degree of splenomegaly is more compared to the degree of hepatomegaly. So this is again a potential Viva question for you. Read Nelson properly and write down the sandbags or Sandhoff disease thing which sir has told you. So let's go to the scenario number 2. Aditya, ready?
Yes, sir.
Okay. Scenario number 2. Take a look. Neonatology coming your way. Neonate delivered at 35 weeks, 6 days by LSCS. He developed progressive respiratory distress at 20 minutes of life and was put on initially oxygen, followed by obviously no improvement. So shifted to nasal CPAP. X-rays showing ground glass opacities and air bronchogram. There was no response to surfactant and he required high ventilatory requirements on ventilation. You are suspecting a surfactant dysfunction disorder. Now, what are the clinical possibilities? Differential diagnosis, 1.5. Basically, you have to talk 3 differential diagnoses, 0.5 for each. What is brain thyroid lung syndrome? If you can just elaborate something about it. 2 techniques to give surfactant apart from ensure. True or false, just like we asked Shravani. And question number 5, pathophysiological difference between congenital alveolar proteinosis and primary alveolar proteinosis. This is something which even ChatGPT gets wrong sometimes. So over to you. From where do you want to start? Aditya, where do you want to start?
I'll start with question number 4, sir. Lung ultrasound can distinguish RDS from TTN.
So what is your answer? True or false?
The answer is true.
Answer is true. Okay.
And third question, name 2 techniques apart from ensure to. The answer is minimally invasive surfactant administration, and which is MISA, and the second one will be LISA. These are the other 2.
Okay.
And I'll start with the first one. Name 3 differential diagnoses or types of the surfactant STD in such a case. I think I couldn't think of the other 2. Maybe
you can for everything you say, you will get credit for that.
Maybe I can think of some cardiac causes.
We are talking about surfactant dysfunction disorders.
Only surfactant dysfunction disorders.
Yes. I know your mind is going towards PDA. We are talking about SDDs.
Yes, sir. And good question, sir. I couldn't think of any other causes in first answer.
Okay.
And I'll answer the fifth one. Tell the basic pathophysiological difference between congenital alveolar proteinosis and primary alveolar proteinosis. I think in this, the onset of pathology will start in utero for congenital alveolar proteinosis, and it will start after birth in primary alveolar proteinosis. I think the child would present quite later in PAP.
Okay.
That would make congenital alveolar proteinosis also one of the differential in the first question. So that would be two.
Is there any difference in the like basic mechanism? They're asking about pathophysiological basis.
Physiological basis. No, sir. Yeah. It's been some time that I read this topic. Yeah.
Okay. So answers to this question. Babu, sir?
Yeah.
Would you like to start, sir?
Yeah. You say. I'll add to those things.
Okay, sir. So we are talking about, basically, this is a newborn who developed a respiratory distress syndrome-like illness, right? RDS-like illness. Ideally, this child should not be considered as RDS because, RDS, respiratory distress syndrome, is due to surfactant deficiency and generally happens below 34 weeks. But AIMS protocol, the third edition, says that up to 2% cases can occur between 35 to 37 week also. So if you are thinking why was surfactant given if it is a late preterm child, you can do sometimes give because there is overwhelming evidence in favor of that. There was no response to surfactant. There was high ventilatory requirement, means it is not shown any response. And surfactant dysfunction disorder should be suspected. You will think of two possibilities broadly. You will think of a condition like hemodynamically significant PDA or some fluid overload kind condition which is causing failure of surfactant, or you will think of conditions like surfactant dysfunction disorder, which are generally autosomal recessive, although dominant conditions also exist. So what are the three differential diagnoses? If you look at the surfactant composition, it has lecithin, it has water, cholesterol, so many proteins. Important proteins are SPA, SPB, SPC, SPT. And among them, it is the three differential diagnoses will be SPB protein deficiency, SPC protein deficiency, ABCA3 deficiency, and TTF1, thyroid transcription factor 1 deficiency as the possibilities. These are distinct conditions that you need to remember. ABCA3 stands for ATP binding cassette protein membrane type 3, and it is involved in the recycling of surfactant in the patient. So these are the three differential diagnoses. You can talk about SPB, you can talk about SPC deficiency, and you can talk about TTF defects. What is brain thyroid lung syndrome? Now, brain thyroid lung syndrome is a condition which is seen in TTF1 deficiency. So thyroid transcription factor 1 deficiency produces three things in the patient. First of all, brain involvement in the form of chorioathetosis. There is thyroid involvement in the form of hypothyroidism, and there is lung involvement in the form of RDS-like illness in the newborn. That is called as brain thyroid lung syndrome. The reason I have included this, it is prominently mentioned in Nelson, and in the last year's Fellowship National Board exam, this was a direct MCQ. So it was something I had shared in my social media profile as an update also about a year back, but I'm not sure if someone has seen that. Right, then name two techniques apart from ensure to give surfactant, very rightly given by Aditya. We have the LISA technique. The gold standard technique is ensure, intubate, surfactant, extubate. Gold standard techniques are less invasive surfactant administration, LISA, and minimally invasive surfactant therapy. These are generally less invasive techniques, and in patients where intubation is a problem, generally these techniques are employed. What is the current status? Something Babu sir can talk about it better. So I will be moving to Babu sir on this. Lung ultrasound can definitely distinguish RDS from TTN. In fact, this is becoming a mainstream modality in some of the tertiary care hospitals. In case of RDS, you will find that evidence of consolidation will be there, whereas TTN, evidence of consolidation is not there, apart from other findings. And finally, congenital alveolar proteinosis is due to deficiency of SPB or similar protein. Primary alveolar proteinosis occurs due to GM-CSF deficiency or antibodies against them, which leads to reduced clearance. One technique requires specific therapy and lung transplant. PAP, primary alveolar proteinosis, responds to lavage of the lungs. Eventually, lung transplant will be needed in that as well. But the outcome, disease severity is different. The congenital form will be more severe, will manifest earlier. PAP can have a intermediate and rarely late childhood presentation as well. That is the basic pathological difference. The first one, CAP, is the SPB protein deficiency related disorder. PAP is GM-CSF related disorder. So, Babu sir, if you could shed some light and some golden points for the students.
Yeah. So amongst three differential diagnoses, you rightly said about SP surfactant protein B and surfactant protein C deficiencies. In addition to that, we have ABCA protein, and there is also one protein by name NNFK3 protein. And in fact, this brain thyroid lung syndrome can also be cause of surfactant protein deficiency because of its genetic nature. That could also be answer for question number one. So as he was mentioning about, Aditya was mentioning about the cardiac cause. So closest differential diagnosis which mimics RDS is TAPVC. So TAP is supracardiac and infracardiac. Predominantly 65% of times supracardiac. If it is obstructed, X-ray will be exactly like RDS. So you give surfactant to a baby, so baby is not improving. We have to think in terms of TAPVC first before we go to various causes like this of congenital surfactant deficiencies. And with to question number 3, and Dr. Sandeep, you are also saying that about 2% of babies may have RDS from who are late preterm, 34, 35, 36 weeks. So even RDS can even be in term babies as well, beyond 37 weeks. So the 0.3, 0.5%, although the severity can be variable. With regard to question number 3, different techniques. So standard terminology is MIST, which is minimally invasive surfactant therapy. ISA and LISA is also the other technique. And apart from ensure, one more technique is nebulization. Although it is not commonly followed, but in the exam, if you say surfactant nebulization as a modality of administration, it is acceptable. And with regard to lung ultrasound to distinguish between RDS and TTN, it is rightly said RDS almost looks like a pneumonia on when we do both direct and then the 2D image also. It will show things like consolidation only, wherein we can see air bronchogram also, which is not clearly seen in TTNB. Air bronchogram is not seen.
Like shreds will be there.
Yeah. So TTNB will have this A lines and B lines. Even in ultrasound, they'll have B lines. And RDS will have shrunken lung, will present with distended lungs, because expiration is blocked at the level of with a very thickening. And I think that's it. And most of the points have been nicely discussed on this. This is an important question because this is very favorite question. I mean, people know, all the people, usually everybody will be knowing about RDS. If you have to go one step beyond that, they usually go to the congenital things, surfactant disorders. So we have to, it's not much, it's not very vast. It is limited, and it's always very good in reading this to make yourself differentiated from top ones.
Correct, sir. One advice to everyone who's listening to this, sir has summarized everything. Babu sir, one question from my side also. Like you are working in a tertiary care, I am more of a general pediatrics practice. Out of Lisa and Mist, sir, which one are you doing?
We are doing Lisa, wherein we are actually taking, babies on, CPAP. We do not during procedure. We, extend the baby's neck, and with a catheter, we push the, there is a holder which is called as a tooth holder, with which we hold the catheter and push with laryngoscopic visualization. It goes into the trachea, and we remove the laryngoscope. We keep the catheter in the larynx, in the trachea, and CPAP is continued. The baby is also on CPAP, and we push the surfactant in slowly in multiple lollipops. So herein, basically, what we are doing is we are not intubating the child with endotracheal tube. Even one breath is known to cause damage, and things like BPD, even a single breath. So to make it least invasive, to make it baby friendly, and to make things as effective as we do in Ensure technique. So this is forward, and both are very good in terms of the clinical outcomes. But then in Lisa or Miss Therapy, we have to actually, it depends on the expert. The person who's doing should directly, target to the vocal cords. He should know how the vocal cords are positioned, and we have to go and hit. The issue comes, the catheter might get kinked, and it becomes a little difficult for a person to put it through. So the area of visualization, field of visualization is very minimal. But if you keep on doing first, second, third, fourth time, you'll get a hang of it.
So it's like putting a central line, na? Well, first time you put, you never hit it.
Correct.
And then eventually your hands gets through. So students who are listening to this and those who will be listening to this on YouTube, if you are listening. So I just want to tell you that in your day-to-day practice as a general pediatrician, as a neonatologist, you will be dealing with RDS only. But sometimes RDS will not be responding. You have to then think of other possibilities. As Babu sir said, cardiac cause should be thought first, followed by the rare causes. It is a rare cause, but it is an important cause. Now, tomorrow, if you have to sit in an entrance exam, or you have to appear for an interview, or a viva, or you are, applying to a fellowship, and you have a OSCE exam, or you have a case scenario discussion, RDS as a diagnosis will not be asked to you because everyone knows RDS. They would be interested in knowing, do you know surfactant dysfunction disorder or not? This topic has been covered well in AIMS protocol. This has been covered well in Nelson, but both of them are insufficient in the two resources. So you have to combine both of them and read. That would be the perfect way to read this topic.
Correct.
Right. So I think Aditya has got a total score. Tough question. A bit of luck also comes into play. He has got a total score of 1.5. Not bad in a tough question. So Bablu, you can write Aditya is 1.5. Okay.
So total score 1.5, right, sir?
Yes, Aditya has scored 1.5. Now we have the third student. Who's the third one? Please identify yourself.
Sobik Mondal, sir.
Sobik. Hi, Sobik. Ready? Should I share?
Yes, sir.
Okay. Scenario number 3. And here comes the cardiology for you.
Should you read, Dr.
I will read, sir. Neonate was brought to pediatric emergency on day 3 of life with shock, absent pulses, and oliguria. There was no response to fluid boluses as well as starting catecholamines. Bedside echo revealed poor perfusion in the descending aorta. You started alprostadil and noticed improvement in the clinical status. So basically, they are asking is there was a newborn. He has been brought in refractory shock, no response to the usual therapy. Bedside echo is revealing poor perfusion in descending aorta. You need to interpret. Alprostadil was started. That caused some improvement. 3 differential diagnoses or the types of the disease. STD is it's some misprinting. 3 differential diagnoses in such a case. You will think of 3 clinical possibilities. You will think of which you can see on echocardiography, producing a picture like this. Second question is Norwood-Seno procedure. It's a one-liner. Even if you can't get the answer correct, we name the condition where Norwood-Seno procedure is used. two important side effects of alprostadil. It has to be too specific only. You cannot say nausea, vomiting, diarrhea, rash, just like you say for any drug in MBBS time. KD Tripathi will not work. It has to be specific. Tricuspid atresia, alprostadil is helpful. True or false? No reasoning needed. And then half mark for where is Daniels's surgery done? Where is JTN's procedure done? Daniels's surgery, by the way, is again Fellowship National Board question of last year. So let us start. Souvik,
Sir, three
where
different.
do you want to start with?
Number one, sir.
Okay, number one. What are we looking at, Souvik?
The diagnosis, sir, coarctation of aorta.
Okay.
One. Next, sir,
You have to
hypoplastic,
tell three. You have to tell three.
hypoplastic left heart syndrome
Okay.
and severe aortic stenosis.
Okay. Question number, which other question? Any other possibility or you are fine with it?
Sir, I am fine with it.
Okay. Which other question you want to answer?
Then, sir, tricuspid atresia, helpful or not? Alprostadil. In case of tricuspid.
True or false? You have to say true or false.
Sir, may be helpful if there is no atrial septal defect or VSD.
No, just
Sir,
yes or
sir,
no.
false,
There is
false,
no.
false.
Okay. Okay.
Sir, number 5.
Hmm.
Chechen's arterial switch procedure is done for TGA.
Okay. You have to be specific. Which PGA?
Sir, which
Whatever TGA comes to your mind, you have to tell the type of TGA.
Sir, arterial switch procedure, sir.
Yes, you're right. But which TGA? Where do you do the typical JTN's procedure?
Sir,
that will not change the answer. I'm just interested in knowing. Don't panic.
Okay, sir.
Okay. What other question you want to mark?
Norwood-Sano procedure is done for Norwood-Sano coarctation of aorta.
Okay.
And Danielson surgery, I don't know. Side effect of alprostadil. Sir, one is hypotension.
Okay.
But I don't know that. Specific.
And you don't know the other?
No, sir.
Okay. So where do we start? Babu, sir? Sir, you want to start? Or should I do the dirty work? Babu, sir? You're there, sir?
I'm there.
Yes, sir.
So name 3 differential diagnoses. So if you see here, there is severe shock, absent pulses, and oliguria, which means this is duct-dependent systemic circulation, which is hampered because the day of presentation is on day 3, at which usually the duct closes. So we have to think in those terms. So the answer given is, I think one is coarctation of aorta, second is
hypoplastic left heart syndrome.
Yeah, hypoplastic left heart syndrome, and third one is critical
Severe aortic
stenosis. I think we should.
Yes, sir. He will get full credit. Apart from that, there are some other disorders like interrupted aortic arch syndrome, or variations of aortic arch hypoplasia. They can also present like that, where the opening the ductus arteriosus will be important to restore blood supply to the descending aorta. So, sir, we can give
he was
1.5 marks to this.
Saying critical aortic stenosis. Had he said just critical aortic stenosis, it wouldn't have been correct.
Sir, severe,
Yes.
I have said.
Severe, he said. Severe critical, sir, we can take, I think. It's mentioned severe only in some textbooks.
Yeah.
Yes. So, good one. Question number 2. Norwood-Sano procedure. Is it done in coarctation? You answered coarctation.
I have forgot it, sir.
Norwood-Sano procedure is done in hypoplastic left heart syndrome.
Yeah. one of your differential diagnoses that you told.
Exactly. Yes, it was one of the differential diagnoses. It's a one-liner. Basically, Norwood-Sano procedure, what we do is, there are stages that we do. Hypoplastic left heart syndrome, what has happened is the left side of the heart and the ascending aorta, that is hypoplastic, that is not formed. So you do staged procedure. In this procedure, what we do is, first of all, you will be giving prostaglandin to stabilize the patient, shift to ICU. In the first week of life, preferably, you will create a new aorta. You will create a new aorta by attaching the segment. Basically, you will attach the pulmonary artery to the redundant aorta and try to enlarge it. So that is stage 1 procedure, which is done in the first week of life. In the second week of life, you will be in the second month of life onwards, you will do a procedure known as Glenn shunt procedure. Third stage, you will be doing a Fontan procedure. And when you perform all these together, that is called as Norwood-Sano procedure. Now, let me put it very clearly. There are many variations of this. If you read the cardiology textbooks in detail, Norwood-Sano procedure is sometimes described separately, and sometimes these three procedures which I told you are described separately. But as a one-liner, Nelson, if you try to read, it combines all of them and it says it is the basic principle behind Norwood-Sano procedure, and it is one of the relatively common procedure done for hypoplastic left heart syndrome. So, name two most common side effects of Alpro. So, Norwood-Sano procedure, he doesn't get any marks on this. Sir, he answered two common side effects of Alprostadil. The commonest side effect, sir, you know.
Yeah, most commonest side effect is apnea, which is why
Yes.
we are starting Alprostadil. We make sure that things for ventilation, intubation, all those things have to be kept aside besides the baby, because baby can go into apnea at any point of time. It is said that around, in the textbooks, old textbooks, it was said that around 60% of the babies may have apnea. But in reality, we hardly see around 10% or 20% babies going into apnea. Other thing that we see is these babies go into flushing. They get well flushed and they look red. That is another very common side effect. And then fever is also one effect that is noticed. So we end up starting with IV antibiotics to these babies who are on Alprostadil because of fever thing. So apart from this, all other things are there. Tachycardia, all those things are there.
Sir, hypotension, I don't think will be the correct answer here, because the patient has already presented with hypotension. Giving Alprostadil will actually cause improvement in the BP. It will not cause hypotension in the patient, because that will open the ductus arteriosus and restore. As a general thing of Alprostadil, you can remember that it can, in a few patients, non-cardiac patients, it can cause hypotension when it is used occasionally. Non-cardiac means neonatal cardiac emergency patient. But generally, the side effects, as sir rightly said, if you read Nelson, if you read Ames protocol, if you read even your Park's cardiology, they say apnea, flushing fever. Apnea, flushing fever. Just remember AFF. Apnea, flushing fever are the ones you need to remember. And if you don't have a bag and mask ready, when a patient is on Alprostadil, it is trouble waiting for you. As Babu sir said, sometimes sudden apnea in a relatively stable child can happen in the patient. Question number 4, tricuspid atresia, Alprostadil is helpful. True or false? We are not talking about the variations. This will be there, that will be there. What is tricuspid atresia? You need to understand. There is no tricuspid valve. It is replaced by a fibrous band. So how would blood reach the right ventricle? The blood has to go from right atrium to left atrium. So there should be a ASD or patent foramen ovale. Then this blood will reach the left ventricle. From left ventricle, there should be a VSD. If it is not there, patient will abort in utero. He will not come into this world practically. Okay. Now there has to be a ASD and VSD. And the amount of blood reaching right ventricle will be dependent upon the size of these defects. Understood? Now, generally what it is seen is tricuspid atresia, the VSD and ASD size is not that great. Variations do exist, but it is not that great. So the right ventricle blood will always be less in amount, which is responsible for, if you look at the classification, tricuspid atresia, Abstein's anomaly, even TOF, tetralogy of Fallot, they all are conditions with reduced pulmonary blood flow. Giving Alprostadil does help in improvement if it is a restrictive ASD or VSD, which is the case in a good number of these patients. So tricuspid atresia is actually categorized as a ductus-dependent pulmonary circulatory lesion. The three conditions that we discussed in the beginning, they were ductus-dependent systemic lesion. Systemic circulation is being maintained. Tricuspid atresia, pulmonary atresia, Abstein's anomaly, they all are considered as ductus-dependent pulmonary lesion. So alprostadil will be helpful. So unfortunately, you lose some numbers here. So, Babu sir, anything on duct-dependent lesions, sir? Pulmonary lesions, sir?
Yeah.
You manage them in real world, sir.
Yeah. When for all duct-dependent pulmonary lesions, we start with alprostadil first, and it actually gives. It's only to buy time before we plan for surgery. It's not a therapy which we give for lifetime. So whenever we're planning for a solution in terms of offering various kinds of surgeries, when we are taking opinion from pediatric cardiothoracic surgeon, when it needs a lot of planning and programming, we need to have some orientation in terms of what kind of surgery, what kind of incision. All this will take little time, maybe a day, 2 days, 3 days, based on the scenario. So for buying time, we start with alprostadil. But only one disease where we're little afraid to start alprostadil is obstructed TAPVC. In all other conditions, we start with alprostadil. So in obstructed TAPVC, what happens is there is, pulmonary venous drainage obstruction is there, and when the duct is getting closed, maybe baby is actually going to improve. But when we are trying to keep the duct open and try to flush it from aorta into the pulmonary system, we are actually worsening the baby's condition. So that is the only one condition wherein we have to be little skeptical when starting PG1. Otherwise, in all other cyanotic duct-dependent, pulmonary-dependent, duct-dependent pulmonary circulation, we have to start alprostadil. And tricuspid atresia, we have to start.
I have a doubt.
Yes, please.
Sir, in HLH also, we won't start prostaglandins because it will flood the lungs. Hello, can you hear me?
Yeah. I'm hearing you. So
yes, sir. HLH is also one of the contraindication for prostaglandin infusion, right?
Not an absolute contraindication. In HLHs, there is systemic circulation which is hampered. So we have to give the systemic circulation via the pulmonary circulation. So that the only way to give via pulmonary circulation is keeping the duct open. But over a period of time, when the systemic pressures are much more higher, then there can be left to right shunting that can happen, causing this. But that happens a little later, not earlier. In the earlier times, in the initial weeks, pulmonary pressures on the higher side.
Rightly said, sir. Basically, in simple language, if I have to tell Aditya, good question asked. Basically, क्या है कि HLHS में what is happening? The left ventricle and the left side of the heart, basically, the left side is circulation, proximal circulation, that is hypoplastic. Okay. You are normally imagining, normal people, you and me, what happens is aorta has more pressure, pulmonary artery has less pressure, right? This is what normally happens. In HS patient, when he presents to you, the aorta has less pressure. It has minimal pressure. It has no pressure. That is why there is, shock happening in the child. So when you open the ductus arteriosus, when you open it, it is connecting pulmonary artery with the aorta. You and me, blood will always move from aorta to pulmonary artery. But in HLHS, blood moves from pulmonary artery to aorta in the descending aorta, and it allows some BP to pick up. Now you may say, sir, it is deoxygenated blood. Bhai, some blood is better than no blood, and even deoxygenated blood has some oxygen. But as Babu sir said, you cannot continue it indefinitely because eventually the pressure in aorta is seen to start rising and the responsiveness also starts to come down. So you need to do an urgent emergency surgery in the first week of life in such patients. But in these patients, when you give alprostadil, there is no pulmonary congestion happening because blood is moving from pulmonary system into the descending aorta. Right?
Yeah.
Understood? Aditya?
Yes, sir. But if it's a
you
mild
can
variant,
get back
some
to me.
mitral obstruction, it might be.
Yeah. Please.
Okay, sir. Yeah.
You can get back to me again on the I cannot have otherwise I would make that shunt for you and it will be easy for us. But just remember, there is no pulmonary venous congestion which is happening, and there's no pulmonary overflooding, because here the blood moves when you start alprostadil, moves from pulmonary system to the systemic circulation. It is a duct-dependent systemic lesion. And question number 5, tell the underlying condition for which the following surgeries are done. Jayton's arterial switch operation is done in dextrose TGA. It should be right. So it's a corrective surgery done in these patients. Babu sir, are we actually doing Jayton's procedure? Like, what's the success rate you are seeing, sir?
We are seeing success rate of around 70% of children if they are coming at right time and if there is no sepsis. So up to 60-70%, and there are many modifications that we are seeing now. This is just the original one which is described. So
Yes,
from the modifications and comfort of the surgeon, the outcomes are differing. Again, it depends on the weight of the baby and time at presentation, all those things.
yes, sir. So whatever you are reading in Nelson right now, that is most important for your exam. But Nelson, you need to understand it's just the basic and it's a textbook. Real world, it's a fascinating world waiting for all of you. So
Yeah.
I hope all of you are just going to enter into it. And not just in the medical colleges. See, top tier medical colleges, you will be seeing all these things. But a lot of work is happening in the private sector as well. Obviously, that time will come at a later stage for all of you. That's why I'm asking all these things to Babu sir, because I keep hearing about all these. But sir is the one who's actually, dealing with all this. And sir, Danielson surgery, he could not remember. Danielson's surgery is a one-liner basically. It's taken from all the standard textbooks. It is done in Epstein's anomaly. In Epstein's anomaly, you can do multiple procedures. One of them is Danielson's surgery. Practically, we don't really do it, and Epstein's anomaly doesn't have a very good outcome. Sir, your views on Epstein's anomaly and the surgeries?
Yeah, Epstein's anomaly is one of the good diseases that, if at all, baby definitely needs to have, because it gives time. Maybe 1 year, 2 years, 3 years, 5 years also. Children, they grow up with Epstein's and can come. And again, Epstein's is a spectrum of disease. HLH is again actually a spectrum of disease. The aortic stenosis is actually part of the spectrum of HLH.
Yes.
Mitral valve absence, which Aditya was speaking, is also part of HLH. HLH also has a whole lot of 7-8 types of spectrums of presentations. Usually, HLH in India, very few centers do the surgeries because outcomes are very bad, and it depends on the ventricular mass that is present and which can be corrected. Epstein's is a good disease. Usually there are no things like sudden death that will happen in Epstein's. But in HLH, there can be a sudden death that can happen.
Correct, sir. Correct. So, Aditya, the mitral valve involvement, if it happens in HLHS, those possibilities can cause a problem there. But that spectrum is very, very rare, as Babu sir has said. There are sub-classifications of all these diseases that we are reading. So we always have to go by the most common variety. And the most common variety, you will have patient not having the less degree of mitral valve, but it is the aortic valve involvement which is predominant, and that is why alprostadil is useful in such patient. So Danielson's surgery, abstinence anomaly. So he has got 1.5 correct. Souvik has got in the first question. Second question was wrong. Third question was wrong. Fourth also got wrong, and here he got half a mark because it was 0.5. So he has got a total score of 2 out of 5. So total score of Souvik is 2 out of 5. Bablu, Ravi, you can note 2 out of 5.
Yes, sir, noted.
So we have three toppers with us. They have done excellent job, great job. Shravani has got 3 out of 5. Aditya has got 1.5 out of 5. Tough luck. Surfactant dysfunction nahi pada shayad. And Souvik 2 out of 5. So where is Ravi? Is Ravi here?
No, sir, his network is bad.
Network is bad. So I think we'll have to announce. I think.
Yes, sir.
So Shravani, you are there? I'm just removing the screen now. They're just coming back
Yes,
now.
sir.
Just a minute. I will remove the screen. Stop share. Okay. So congratulations, Dr. Shravani. You
Thank you,
have
sir.
done excellently well and you have scored well. And in fact, it's not just about doing it well. You were doing well in the original MCQ round as well. So very well done. Congratulations on behalf of the entire team. And all those who didn't do well, Aditya and Souvik, great job. Sometimes it comes down to, that last minute thing कि मैंने वो topic पढ़ा कि नहीं, whether it struck to me at the right time or not. And a lot of us, Babu sir has been a topper. At PGI, I was a very, mid-ranker kind of काम चलाने वाला. Quiz नहीं जीता मैं कोई भी. पर बाद में, what matters is you love your thing or not, and you can manage the things or not, right? So eventually it comes down to that. And you people have reached at this level. First you cleared that, then you reached here. So you are all winners. And congratulations to all three of you. Any comments from you, Souvik, Aditya, and Shravani?
Yeah, my perception is all are winners. I mean, not just we are saying. It was the app which gave marks and decided, but all were real brilliant. I enjoyed thorough session. Everybody's giving good inputs, and it was really interesting to understand the students who have been trying to go into the nitty-gritties of the topics. And these topics are really random, although relevant, but topics were really random. So at times, because of the luck and other issues, we may mark it rightly or may not, 0.5 here and there. But eventually, this is what actually matters this is how it happens in the main exams. So we have to be ready with all. So congratulations to all the 7 of you.
And all those who could not do but are still here, Dr. Ravi Prakash, he was working in the emergency and still attending it. Great job, all of you. I think pediatrics is going into the right hands. And let me tell you one thing. When you are working in a medical college or you open social media or Twitter, people are putting up all those kind of things, no opportunities, doctors have no jobs, doctors have not this, doctors. Don't look at it. You have a lot of opportunities. The only question is, are you good in whatever you are doing or not? There is a world of opportunities waiting you in the government field, in the field of medical colleges, in corporate hospitals, in the fields of super specialty and fellowships, if you want to do that. And if you want to go the traditional way of, doing a city-based small practice, pediatrics does open you a world of opportunities. You just need to, believe in doing the best that you are doing right now. Crack your MD or DNB, think about kaage kya karna hai, and whatever field you move in, you are going to do great. So congratulations to all of you, and hopefully we stay connected. आप लोगों का जो भी rewards है and everything है, वो रवि के पास details हैं, but Ravi is missing. So we'll keep it. You are all active on the WhatsApp group as well. So details will be shared in the WhatsApp group, and you can reach out to me and Babu sir anytime. And for those who are listening to this YouTube video, myself, Babu sir, Aparna ma'am, Sudeep Verma sir, us and at least 7-8 more people. We have a complete team at DocTutorials, giving you that residency training. We are available for all of you in case you need any assistance from us. But eventually, the best teacher is always your patient, your bedside teaching, a bit of Nelson, and your consultants. Social media can only help you a bit. There is no replacement for your bedside teaching. So no more patronizing and sermon after that. Sir, any last words from you?
Yeah. Very well done. That's it. Very well done. Keep trying, keep striving.
Yes. And thank you so much, sir, for taking out time. You were also traveling to your place and last minute you had to come out. So thank you so much for your time, sir. Thank you. Thank you, everyone. We'll connect soon.
Thank you. Bye.
Great job. Thank you, Pablo. You can close.
Thank you, sir. Yeah, thank you, sir.
Thank you.
Thank you, doctors. Congratulations to all the participants.